such as hiatus hernia or the stricture or the growth that lead to a exposure time of gastric content which has been prolonged, leading to the esophageal ulceration and the erosion and the ulceration. Another thing was if a motility of the esophagus was disturbed or motility is impaired, then also a sense of obstruction or dysphagia would be there. Third was laxity of the gastroesophageal junction leading to a reflux esophagitis. Now, coming to another subject that is with the GERD, the differential diagnosis was infectious origin, systemic or connective tissue disorders, or the substances that is leading to erosion, that is corrosive, or the pill or the drug-induced esophagitis. These are all differential diagnosis for the gastroesophageal reflux disorder. Another disorder which is being related to this gastroesophageal disorder was eosinophilic esophagitis. Eosinophilic esophagitis, as the term it says, it's an immunological disorder induced by antigen sensitization in a susceptible individual. That is any atopic or any allergic substances leading to immunological development or sensitization of the esophagus. The current prevalence, which is being estimated in the United States, was 4 to 6 cases per 10,000. Out of 10,000, that is 4 to 6 cases. It is also being basically says the increased prevalence is attributable to increased incidence as well as the increased recognition of the condition. Not only the condition, the incidence or prevalence has been increased, its condition is also being recognized. That is increased development or use of this esophageal endoscopy and presenting the patient to the primary care physician for the causes. Detection was by male, that is age group, that is 30 to 40 age group is more being the person for developing this disease. Etiology, it says primary dietary factor which plays an important role in the pathogenesis and treatment. GERD, as I said, that's a part of esophageal eosinophilia. Drug-induced hypersensitivity, connective tissue disorder, hypereosinophilic syndrome, Crohn's disease, and infection, which may also result in the development of this esophageal eosinophilia. Symptoms, particularly pre-adolescent group children, will lead complaint of chest pain, abdominal pain, nausea, vomiting. And the primary symptom in pre-adolescent children would be food aversion. That is, after taking food which is being regurgitated or vomited. Adult may complain of typical chest pain with pyrosis, that is heartburn, which is refractory to the use of proton pump inhibitor therapy or PPI therapy. Dysphagia and esophageal food infection is also being a part of this esophageal eosinophilia. Diagnosis typically depends on the esophageal symptom and esophageal mucosal biopsy, demonstrating squamous epithelial eosinophilia, that is predominant of eosinophil in the inflammation in the biopsy. An atopic history of food allergy, asthma, eczema, and allergic rhinitis is also present, that is for the allergens. Peripheral blood eosinophilia is demonstrable in up to only 50% of patients. That is 50% of patients on peripheral blood smear will show eosinophilic or increased eosinophilic count. This is the diagnosis, which says upper GI endoscopy, the diagnostic modality, which typical finding includes loss of muscular marking, that is because of edema. Multiple esophageal rings would be seen, longitudinal oriented furrows, and punctuate exudate would be, white punctuated exudate would be seen. So this is a characteristic upper GI endoscopic finding, that is the multiple esophageal ring, longitudinal oriented furrows, and white punctuate exudates. Histology will result in confirmation with demonstration of esophageal mucosal eosinophilia, that is density more than 15 eosinophil per high power field. So on the basis of biopsy, the high power eosinophil count will be more than 15 eosinophils per high power field. Complication, it says, includes esophageal stricture, which is the most commonest or the related complication is with the esophageal stricture. Increased risks depends on the duration of untreated disease. As the untreated disease prolongs, the risk of esophageal stricture also increased. Narrow caliber esophagus, dysphagia, a feeling of food impaction, and esophageal perforation. These are the four complications. Management, particularly, it says PPI therapy as a means of excluding contribution of gastroesophageal reflux disorder. PPI responsive esophagitis characterized by elimination of mucosal eosinophil. So after therapy with PPI proton pump inhibitor, if a subject, if a patient improves in a symptom or symptomatology, so just it is because of gastroesophageal reflux disorder. 30 to 50% of the suspected cases are because of GERD. A patient with persistent symptoms instead of PPI therapy will lead a further management of further treatment. Like dietary therapy, elimination of diet formula, highly effective therapy, but are limited by palatability. Obviously, taste as a factor for limitation of the diet therapy. Empirical elimination of common food allergens followed by systematic reintroduction has been an effective therapy. So first stop all the dietary factors which is being suspected to be leading to development of esophageal eosinophilia. Thereby reintroduction of food one by one, just for assessing which food is particularly allergen for that. Food like milk, meat, egg, soya, nut and seafood, these are the common allergens for the diet therapy. Next, if diet therapy does not respond, then swallow the topical glucocorticoids, particularly fluticasone, propionate, and budesonide. These are highly effective therapy, but recurrence is common with short term of therapy. In case of refractory diseases or severe disease, systemic glucocorticoids is also being reserved. So, glucocorticoids are the therapy particularly for the major treatment if diet therapy does not respond or does not work. Endoscopic management, it's include dilatation of the fibrostenotic esophagus. It has a high risk because of the chances of mural laceration or perforation of the stiff wall esophagus as a complication of esophageal dilatation. So this is something esophageal eosinophilia. Is there any question? Should I continue?
Yes, sir.
Okay,
Yes, sir.
then,
Yes.
okay, then the next
Yes, sir.
differential diagnosis
Yes.
includes, the next differential diagnosis which includes infectious esophagitis and a part of the esophageal disease. Gastroesophageal reflux disorder, esophageal esophagitis. Then the part is infectious esophagitis. There are few diseases which are more common with the infectious, that is viral herpes and cytomegalovirus, and infectious and the fungal infection, that is candidiasis. The part which it says it is because of increased use of immunosuppression, particularly for organ transplantation as a therapy for the suppression of these organ suppression as the use of organ transplantation, increased use of chemotherapy or increased availability of the use of chemotherapy, radiotherapy, chronic inflammatory disease, and AIDS as an epidemic. So these are the few reasons which is leading to a development of a state of immunosuppression, leading for an infectious disease to be prevailing or very common. Infectious esophagitis has become as common with this immunosuppression. Candida species, herpes virus, cytomegalovirus, these are the common infection in a part of esophageal infectious esophagitis. In a patient with AIDS, particularly it depends on the CD4 count. A decline in CD4 count will lead to a development of infectious esophagitis. That is CD4 count more than 200, which is rare, and the more common is CD4 count less than 100. That is, in a patient with infectious esophagitis like Candida, particularly infection, if a patient is developing in patient with AIDS, we can assess CD4 count is being declined or being decreased. Primary symptom with infectious esophagitis is odynophilia, that is painful deglutination or painful eating. Dysphagia, chest pain, hemorrhage, these are other symptoms my patient may present with these symptoms. Odynophilia is particularly uncommon in gastroesophageal reflux disorder. That is, a patient with gastroesophageal reflux disorder will never complain of painful eating. That is odynophilia. So in a patient with GERD, which patient says patient complaining of odynophagia, then patient may having a co-infection, that is infectious esophagitis with gastroesophageal reflux disorders. So odynophagia is uncommon with GERD. Candida esophagitis, which is the commonest, it's a normal inhabitant of throat that's normally found in throat. Candida albicans is the most common species, can occur with esophagus stasis or diverticula. That is any condition which is impairing the physiological function of the esophagus will lead to a development of the disease. Rhinitis, dysphagia are the common symptom, obviously with infection. Oral thirst may also be present. That is, the patient with the oral candidiasis may also have esophageal candidiasis. Upper GI endoscopy, a characteristic appearance of white plague with friability. This is particularly seen. Complication includes bleeding, perforation, stricture, or systemic invasion. Treatment as a part with antifungal includes fluconazole, that is 200 to 400 milligram first day, followed by 100 to 200 milligram daily for 14 to 21 days. That is, in a patient with esophageal candidiasis, once a weekly therapy is not working. It's a daily therapy of 100 to 200 milligram for 14 to 21 days, with a loading dose of 200 to 400 milligram on the first days. The refractory patient may respond to voriconazole as saconazole. IV echinocandins are also available for severely ill patient. These endocandins are a group of antifungal. Fluconazole was the first drug which was introduced with echinocandins. It is relatively hepatic safe and renal safe. Next group is herpetic esophagitis. That is herpes simplex virus type 1 and type 2 versus esophagitis. Vesicles on nose and lips may also coexist with these herpes esophagitis. Varicella zoster virus is also a cause of infectious esophagitis. Upper GI endoscopy, a typical finding of vesicles and small punched out ulceration is the commonest finding with upper GI endoscopy. Herpes simplex infection is particularly limited to squamous epithelium. Vesicles with small punched out ulceration. A typical ulceration which is also seen, type of ulceration is also seen as skin disease. Biopsy from the ulcer margin, that is from, usually biopsy is taken from ulcer margins from normal esophagus epithelium and the ulcer margin, which reveals a characteristic ground glass nuclei, eosinophilic crowd-right type inclusion bodies, and giant cells. So these are the findings, particularly with biopsy in herpes esophagitis. Treatment is with acyclovir 200 milligram per orally 5 times a day for 7 to 10 days in an immunocompetent patient. That's in an immunocompetent patient, 7 to 10 days of therapy with 200 milligram of acyclovir 5 times a day. In an immunocompromised patient, dose has to be increased to 400 milligram per orally 5 times a day, and duration of therapy has also been increased from 14 to 21 days. So this is treatment with acyclovir. Another group of drug is famciclovir and valacyclovir. Valacyclovir is 500 milligram per orally TID, TDS 3 times a day. Valacyclovir is 1 gram per orally 3 times a day. In a severely ill patient with the severe odynophagia or dysphagia, acyclovir injectable can also be used with a dosing of 5 milligram per kg every 8 hours. That is, injectable dose is not 5 times, but it is 8 hourly with a per kg weight of 5 milligram per kg for a duration of therapy 7 to 14 days. Third, the cytomegalovirus. It is a particular primary seen in immunocompromised patient, particularly organ transplant recipient. It's more common with this group. Cytomegalovirus is usually activated from a latent stage like tuberculosis, which is also activated from latent stage. It is also stage the cytomegalovirus is usually activated from a latent stage. Upper GI endoscopy finding is serpiginous ulcer, particularly in the distal esophagus. So this is a particular finding in upper GI endoscopy. Biopsy from the ulcer base. That was biopsy from the margin. That is from ulcer base, which yields a greater diagnostic finding. Pathognomonic large nuclear or cytoplasmic inclusion body are seen in biopsies. Treatment is ganciclovir 5 milligram per kg every 12 hourly intravenous. Well, ganciclovir 900 milligram per orally every 12 hours. This therapy is to be continued until healing, which may take 3 to 6 weeks. Maintenance therapy may also be needed in a patient with relapsing diseases. So this is up with today's session. Is there any question?